Thank you for having me here again. I'm Olga Klinkova from Moffitt Cancer Center. I see some new faces, some old faces, so thanks for coming. The topic of my lecture today would be on urinary tract infections, and what I have decided to do today, I have 3 cases that we will discuss together. And throughout the cases, we'll go through the management and treatment guidelines or options, how you want to say it, specifically to cover the management of uncomplicated versus complicated urinary tract infection and what they are, some definitions, and just common facts about them. I feel like it's a very important topic to review because we, deal with it every single day. So I'm sure you know about that urinary tract infections we define as the inflammation of the urothelium that either affects your lower urinary tract, in which case we call it cystitis, or upper urinary tract, in which case we call it pyelonephritis. Or it can affect both as well. We'll go over the pathophysiology of the urinary tract infection. So typically what happens in the beginning is that the pathogenesis starts with a colonization of your urethral meatus by uropathogens that come from our fecal flora, basically. And then what happens, those pathogens, they travel by the ascending way into your bladder, where they get settled and causing a lower urinary tract infection or cystitis, or in the cases of upper urinary tract infection or pyelonephritis, the bacteria continues to travel up. So on your left, you see just very basic facts about simple UTIs or cystitis. The most common risk factors are females, prior history of UTIs, recent sexual activity, ongoing or concurrent vaginal infection, and comorbidities such as diabetes, obesity, and even genetic susceptibility has been implicated. So it's a known fact that women are at a higher risk for urinary tract infections just because of the structural anatomy. And what's important to remember that most of the male should not have urinary tract infections unless there is a comorbidity or predisposing risk factors, which we will go over later. The most common clinical presentation of cystitis would be frequent and urgent urination, dysuria, suprapubic pain. So basically, it's symptoms that are localized to the bladder and below. Opposite to pyelonephritis presentation, when you have symptoms that extend beyond your bladder. So we're talking about back pain, flank pain, fevers, chills, and generalized symptoms such as nausea, vomiting, anorexia, and in severe cases, severe sepsis and septic shock can occur. The most common pathogen in both cases would be E. coli, followed by other Enterobacteriaceae, as well as some other pathogens that are listed here. Moving next. So that's exactly what I just mentioned about the microbiology. What is important to remember right now that we're dealing with rising prevalence of ESBL pathogens. And based on the prior literature, the estimated prevalence of ESBL-producing E. coli is about 12%. But what's even more important to remember is that when they looked at the prior studies, 36% of those E. coli-producing ESBL-producing E. coli, they were actually came from the community. Those patients did not even have prior exposure to hospital settings. So that's very alarming, and obviously we have to adapt our treatment options to that. I wanted to show you the results of this one study, which I think was published in 2013. So this is the study on antibiotic resistance among urinary isolates from women. They were treated for urinary tract infection in the outpatient settings back in 2003 and then in 2012. So as you can see, they had a lot of isolates. You see the number was close to 300,000. And most of those isolates, as we already know, they were E. coli's. When they looked at the susceptibilities, what they found is that in the past or more recently, there was a good susceptibility of E. coli to nitrofurantoin, and that remained the case. What they found out is that there was a rise in ciprofloxacin resistance from 3.6 to 11.8%, as well as trimethoprim sulfamethoxazole that went up from 17.2 to 22.2. And just go over some basic definitions. So these are your classic definitions of uncomplicated versus complicated UTI. So classically, uncomplicated UTI is defined as the UTI that occurs in a normal urinary tract, and it is basically a simple cystitis in non-pregnant women without urologic abnormalities. Is it possible that simple cystitis can occur in patients even with comorbidities? Sure. But again, this is your traditional definition. If you look on the right, this is the table that includes the patients that would be considered to have a complicated urinary tract infection. So this would be a UTI that extends beyond the bladder. So we're talking about pyelonephritis, complicated pyelonephritis, other complicated UTI. The patients that have structural or functional urinary tract abnormalities, either very young patients, infants, or older patients, patients that have indwelling catheters or percutaneous draining tubes, patients with nephrolithiasis, spinal cord injury patients, even patients with uncontrolled diabetes, male and pregnant women. So let's talk about case number 1. So we have a healthy 29-year-old female that presented to urgent care center with burning and frequency with urination, 3 days in duration. She denies any fevers, chills, back pain. There's no GYN symptoms, but she does report a new sexual partner. So the questions that I have for you guys, based on her presentation, what would be your diagnosis based on what we discussed? Do you think she needs any additional workup? And how would you treat her?
Uncomplicated.
Complicated UTI or simple cystitis. Do you think she requires any additional workup at this point?
I guess you could do your EUA.
Urinalysis?
Maybe pregnancy test.
Very good. So pregnancy test, urinalysis. If you try to dig into the new sexual partner history, if there are any alarming signs, right, you might consider testing for STD. However, even if you test her for STD, I think based on this, it's reasonable to diagnose her with simple cystitis. And based on this information, how would you treat her? Just some options. Very good, very good. Would Bactrim be an option? Potentially, yes, absolutely. Yes. So this is the urinalysis that the patient gave you. So we see that she has some pyuria, 21 to 50, and moderate amount of leukocyte esterase. So is this a significant pyuria? It's mild to moderate, but it's there, right? And what do you guys remember about leukocyte esterase? Is it sensitive, specific? Is it both? Both ways?
Yeah, I thought it was. I thought it was low on both sensitive.
So yeah, I'll show it to you. Okay. So we diagnosed this patient with uncomplicated UTI or simple cystitis. Based on her urinalysis, we determined that she has significant pyuria, which is defined as a pyuria in a clean catch sample of equal or more than 10 white blood cells in a microliter. She had positive leukocyte esterase, so this is the enzyme which is released by leukocytes, and this is the enzyme that even the urine dipsticks pick up. Okay. Remember, there is also a nitrate, right? That is produced by Enterobacteriaceae if they are present in the urine. And the mechanism behind it is that the bacteria reduces nitrate into nitrite, and that's what the test picks up. So I was actually curious even to know myself, because I forgot what exactly happens with those tests. So this is the table number 1 that I'm showing to you on the causes of false positive and false negative urinalysis results. And that was published in American Family Physician, just on how you interpret urinalysis. So what you can see here is that leukocyte esterase can be falsely positive with contaminated urinalysis. And the same could be true with positive nitrites. As well as nitrates are very picky, and they can actually be positive if that dipstick is exposed to the air for an appropriate time, and if the urine contains phenazopyridines as well. And to look specifically on the sensitivity and specificity numbers for both nitrates and leukocyte esterase. So this is the table. They looked specifically at the culture-confirmed UTIs. And what they found out is that the leukocyte esterase had a sensitivity of 72 to up to 97%. However, the specificity range was wide, 41 to 86. However, if you look at the nitrites, it was found to be very specific, 92 to 100%. However, the sensitivity of positive nitrites was only 19 to 48. So that's something important to keep in mind. So when we say, okay, was the nitrite leukocyte esterase positive, again, remember about the sensitivity for nitrites, right? They might not necessarily be positive. So I think we decided on that patient that there was no indications to obtain culture, correct? And that would be the correct answer. So based on the current recommendations or guidelines, the urine culture is recommended to obtain only in this case scenarios. If you have a patient with complicated UTI, suspected pyelonephritis, history of recurrent UTIs, if routine treatments are not available because of, most often it's an allergy history of the patient, or if you strongly suspect the presence of a resistant organism. Also remember that asymptomatic patients, there are only 2 categories that we would screen, right, for asymptomatic bacteria. Number 1 would be pregnant women, and number 2 is all patients that undergo invasive urologic procedure with anticipated damage of GU mucosa. So those patients would undergo screening urine culture before going for the procedure. So these are the recommended regimens for the treatment of simple cystitis or uncomplicated UTI, specifically in the female. So nitrofurantoin, several of you guys mentioned, so this is definitely an excellent option. Bactrim is an excellent option, as well as fosfomycin. As you can see, the fluoroquinolones dropped from the primary regimens based on the most recent recommendations for two reasons. There is a very high resistant rates that we're observing in the community, and number two, I always like to mention, remember that a few years ago, actually FDA issued a black box warning specifically for the fluoroquinolones and the variety of side effects that they can cause. However, fluoroquinolones would remain into your alternative regimens, as well as they would remain as your primary regimen for more severe infections such as complicated UTI. We'll talk about it very soon. So remember, Bactrim, nitrofurantoin, and fosfomycin, your three main drugs for the treatment of simple cystitis or uncomplicated UTI in a female. And I just placed this table in case somebody like me likes to look at the tables. So it's just the screenshot that was from the paper which was published in CID back in 2013. So remember, uncomplicated UTI, the recommended duration is 3 to 7 days, except in a pregnant female, it is recommended to treat them for 7 days. And we have a second case. So we have a 47-year-old male who has relatively controlled diabetes. His A1C is 6.5, who presented with burning with urination, mild suprapubic pain for 2 days in duration. He has no other symptoms. You obtain urinalysis in the office, and he has a mild to moderate pyuria with white blood cell count of 21 to 50 and moderately positive leukocyte esterase. So this is a little trickier situation, right? So based on what we discussed right now, what do you think is a type of a UTI that we're dealing with here? Would you proceed the culture, and would you initiate empiric therapy, and what would you go for? Is there any other factors you would like to evaluate him for or do any further workup? Okay.
You'd want to know if he has any other prostate issues, any anatomic issues.
Very good. Excellent.
Sexual history as well.
Very good. Very good. Excellent. So based on the classic definition of uncomplicated versus complicated UTI, as we discussed, because he is a male, he would fall under complicated UTI category. Remember that uncontrolled diabetes would fall under complicated UTI category as well. And I'm just bringing up the same table. You know, if you look at the literature these days, I think there is not enough very strong data, but you know, traditionally we say that the patients that are male, have comorbidities, should be categorized into complicated UTI, but you know, some of those patients, for sure, they can have uncomplicated UTI, and the question becomes, is there a patient that I can identify that potentially would benefit from a shorter duration of therapy, right, rather than given the 7 days. So what the literature tells you that potentially there are patients that are can be treated with shorter courses of antibiotics, but the patients in complicated UTI category, these are the patients that are higher risk for complications. They need to be closely followed, and you absolutely have to make sure that those patients do not exhibit signs that would, go beyond the bladder, any signs that would point you towards a complicated UTI history. I think if you identify a relatively healthy patient that based on the history, you are convinced that this is just a simple cystitis, even in the male. If you can monitor that patient very closely, a shorter antibiotic duration course might be potentially offered. And as you guys all mentioned that specifically in male, we want to make sure we are ruling out other potential etiologies such as STDs. Urine culture would be recommended, and we would not wait for urine culture. We would have to start him on something, right? So that's just exactly what we mentioned. I think concern for prostatitis was brought up by a couple of you guys. And prostatitis should be always considered in the male, especially if they have a recurrent urinary tract infections or if they have a pelvic rectal pain on review of the system. Specifically in male populations, you should consider imaging to rule out obstruction or any other structural abnormalities that lead to the UTI. Again, as I mentioned in the beginning of the lecture, UTI in a male patient should be evaluated much thoroughly. You should find out why. These are the primary regimens that are listed actually in Stanford antibiotic guides for the treatment of urinary tract infection in adult male. So as you can see, the duration of therapy is a little longer, 7 days. There was not very many, but the literature which was available showed that there was no benefit of treating male patients for more than 7 days. However, they saw more C. diff in the patients that were treated for extended course. So on a primary regimen, again, you see Bactrim, you see fluoroquinolones that you do not see in simple cystitis, remember? And again, nitrofurantoin is here. So specifically for the male population, what is important to remember is that most of the drugs do not have a very good prostatic penetration. And the fluoroquinolone is actually the class that does. So that's why for the male population, fluoroquinolone is still remains in the primary regimen. And let's talk about the case number 3. So this would be probably the most complicated one. So you have a 55-year-old female with a diagnosis of uterine cancer, status post left-sided urethral stent placement 1 year ago, who presented to primary care doctor with pain with urination and back pain for 3 days. She states she started having fevers, significant fevers in the past 24 hours. She was found to be febrile in her primary care's office, otherwise vitals were stable. She was found to have a CVA tenderness. She had leukocytosis on the blood work, and urinalysis showed significant pyuria with positive nitrate test. So what would be your assessment of this situation, and how would you like to proceed? I think the most important determination would be if you think this patient is safe to be treated as an outpatient or should be treated on an inpatient basis.
So clinically.
Very good.
And you would be concerned for any obstructive process, especially if she had a stent in. Is there an obstructive uropathy going on? So she warrants further workup, probably inpatient with some ultrasounds. Yeah, and then the traditional UA, you monitor with IV, so maybe some tracks.
Okay. So we determined that this patient should go to the hospital, right? We determined that she would need a further workup with urine culture, probably blood cultures. If we think that she is septic, which she definitely could be, then other sepsis workup, including lactic acid, would be very appropriate in this patient. Okay. So remember that pyelonephritis by definition is acute complicated urinary tract infection with typical manifestations being fevers, UTI symptoms, and CVA tenderness. Complicated pyelonephritis is a pyelonephritis that, on the top what I just mentioned, is associated or occurs in the patient that has a known or just diagnosed obstruction. Is the patients that have indwelling catheters, percutaneous nephrostomy tubes, or renal stents put in. And also, a lot of times, patients post-transplant would be classified under this category too, if they have a diagnosis of pyelonephritis. So these are most of the indications for hospitalization that I mentioned on this slide. So the patients that you are concerned for sepsis, obviously shock, patients with a new acute kidney injury, patients with uncontrolled pain, marked other comorbidities or debility, patients with unreliable PO intake, or unreliable adherence to your medications in settings of sepsis should be hospitalized. And again, if you're concerned about the obstruction, that would need to be ruled out on a very expedited nature, right? So most of those patients would at least need to go to the emergency room to get initial workup initiated. How would you stratify this patient in terms of which antibiotics would you consider using?
I guess one thing for that is because she has the stent, she may be colonizing more resistant organisms.
Okay.
So I guess you would think maybe something like Zosyn for Enterococcus pseudomonas coverage for that reason.
Okay.
Whereas if she was a straightforward pyelonephritis, maybe something like ceftriaxone would work. So those would be the two that would delineate between.
Okay. Any other risk factors that you would that you think would put her on at risk for MDR-cotic category?
History of MDR. History.
So prior urinary isolation. Okay. So yes, as we discussed, so the next step would be to evaluate that particular patient for the risk factor of the risk factors for MDR to choose the appropriate antibiotic regimen. And the four most important risk factors that we should keep in our mind is that number one is a prior isolation of MDR in the urine. And that a lot of times we can actually check just by going to the prior culture data. Inpatient stay in a healthcare facility, so they list hospital, nursing home, or long-term care facility. And if you look at the literature, they actually they do not give you a time interval since exposure either to the healthcare facility or to antibiotics. Comparing, let's say, to CAP, right, when they tell us 90 days. But again, those risk factors should be evaluated by, history and reviewing patients' records. So another very important risk factors would be a prior use of antibiotics, broad-spectrum antibiotics, specifically fluoroquinolones, Bactrim, beta-lactam use. So also keep in mind that patients that just got a single dose, even for prostate procedure, would be considered at risk for multi-drug resistant organism already, even after a single dose of antibiotics. So that's important to keep in mind. And again, a lot of times we would use clinical judgment. Let's say if we have a patient who are we admitting who is relatively stable, there might not be an urgent need to start them on our top priority antibiotics such as carbapenem, right? Versus a patient that we're admitting, let's say, to ICU from urosepsis. And one more risk factor that I would mention that we should keep in mind is that travel to the parts of the world with a high rates of MDR. So those countries would be India, Israel, Spain, Mexico. So those four were found to have higher rates of MDRs. So in the outpatient settings, even patients with pyelonephritis sometimes can be treated as an outpatient, right? So if they are stable and they do not have those concerning findings that would require admission, potentially those patients can be managed as an outpatient. A lot of recommendations these days would use a fluoroquinolone resistance rate to give you choices what you are supposed to use. And basically, if your local fluoroquinolone resistant rate in the community less than 10%, fluoroquinolones considered an appropriate option. So either ciprofloxacin or levofloxacin. Alternatively, if these are not the option, ceftriaxone daily, IV daily infusion for 10 days would be an alternative. The patients that are treated in the outpatient settings in the communities with a high rate of fluoroquinolone resistance, on day one should receive intravenous ceftriaxone or ertapenem, or intramuscular gentamicin or tobramycin can be used as well. And this can be followed by a fluoroquinolone course if a patient is stable. Alternatively, if fluoroquinolone is contraindicated or there is an intolerance, potentially other antibiotics can be considered once patient receives the IV infusion on the first day. So that's for the outpatient setting specifically. The patients that appeared ill on presentation or slow to respond potentially should finish therapy with IV, all along without the escalation to oral agents. And then a couple of days into the treatment, you should receive a urine culture result, and your antibiotic therapy would be tailored if needed based on that. So talking about the treatment of pyelonephritis or other complicated UTIs in the inpatient settings. So it could be this patient potentially, right? If there is no identified MDR flags on this patient, she actually has quite a bit of options, right, that you can use. So we have an option to use something simple as ceftriaxone, Zosyn, but also recommendations still leave you an option of using fluoroquinolone, either IV or even by mouth. In the patients that have MDR risk factors, it is recommended that you would start with carbapenem therapy. Specifically, you have choices that would cover for Pseudomonas. And also, if you have a preliminary urine culture results with isolation of gram-positive cocci, potentially you would also add one of the gram-positive agents such as vancomycin, daptomycin, or linezolid. In the patients with or without multi-drug resistant risk factors that have severe sepsis or shock, presumably due to urosepsis, the recommendations are actually to start with carbapenem therapy plus add the coverage including gram-positive organisms. But I think that would be also consistent with shock, severe sepsis shock guidelines. So in terms of the duration of antibiotic therapy, remember for uncomplicated pyelonephritis, 5 to 7 days might be, and most of the times is sufficient. On the opposite, complicated pyelonephritis or other complicated UTIs oftentimes require longer treatment, up to 14 days. And also, we discussed it before. Remember that in the cases of complicated pyelonephritis, always consider pelvic imaging to rule out obstruction leading to urinary tract infection, and consider urologic consultation if structural abnormalities are found. And I think I will stop here. Any questions?
Can you comment on, because I think we see this a lot, prophylaxis or chronic suppressive therapy for recurrent UTIs, and how you kind of approach that?
So it is generally not recommended any longer.
Okay.
If you look at the older literature, even literature back in 2013, I'm citing this one paper was published in CID, it still mentioned prophylaxis. However, most recent guidelines do not recommend it because of the risk of resistance and C. diff and other side effects related to chronic antibiotic use.
And so do you have a hard, so we see this, I think, more so here at the VA than the other two sites, but have you faced challenges with trying to get patients off? Like, do you see those patients in your...
So actually, believe it or not, at Moffitt, sometimes we do get requests from GYN. I think because of the nature of their cancers, their and higher rates of obstructions, they are just naturally at higher risk for UTIs. We do receive requests to evaluate them for suppression, and we actually don't recommend doing that.
About asymptomatic patients that are going for a urologic procedure, so UA's positive, urine culture grows something, how do you do the full course? Do you do an abbreviated course?
Based on the current recommendations, so those patients undergo an urologic procedure. If that would include the GU mucosa damage, the recommendations are to screen them. If the urine culture is positive, that you would prophylax them in perioperative period with antibiotic that would cover what is grown, but you would use guidelines for prophylaxis, which means you limit it to 1 to 2 doses, basically. So let's say even if it's a patient that undergoes a procedure, if you have no symptoms but positive urinalysis and culture, that patient still falls on the category of asymptomatic bacteriuria, which would only need to be treated for procedure. Any other questions or comments? Dr. Tony or Dr. Vega? No?
No, I mean, to Vidya's question, I guess one case in which I may consider not so much prophylaxis, but an empiric therapy in young females that are sexually active that are having recurrent UTIs related to
Sexual intercourse.
Sexual
Mhm.
intercourse. I have in the past prescribed nitrofurantoin, for example, for them to have with them
Yes.
at the onset of symptoms, because it is a very real thing and it happens, and they'll get like
Yes.
6, 7, 8, 10, 12 UTIs a year.
Mhm.
I don't want them suffering. So at the onset of symptoms, after, I usually go over all the other antibiotic things that they should be doing to
Right.
prevent
Right.
UTIs, but I have given them some antibiotics to take with them,
Like a 3-day supply.
3 days apart once, and then just to start them if they develop symptoms immediately.
Got it.
It's actually in the literature to use it for post-intercourse.
Say that again, I'm sorry?
It's in the literature that you can use it specifically post-intercourse.
Yes.
Yes.
So in a way, it's kind of like prophylaxis.
Yes,
It's
I guess.
more, you're not just randomly given
Right.
them antibiotics to take
Mhm.
whenever. It's at the onset of symptoms.
Mhm.
So it's still empiric and it's still sort of preventive, but not really.
Yeah.
Yeah.
I think there is actually literature that you can use it with intercourse, right?
Mhm.
If
Even
you're
without the onset of symptoms.
yes, right.
Correct.
If
So in a
if
way,
you are
it's
such a high risk.
prophylactic.
Mhm.
Yeah. Like I said, it's just like, most of my examples, they become symptomatic, they'll take the antibiotic, it's still a good 6 to 12 hours before they have relief, and it's pretty intense
Yes.
pain,
Mhm.
so, so sometimes I tell them to just take it. But, how sexually active are you? For a year,
That's
how
the
many
issue.
times are we gonna do this?
Right. Yes. Yes.
So,
Yes.
that's why sometimes I tell them, 5 hours of misery versus just taking antibiotics every time you're, right?
Mhm.
So.
No, I agree. Yeah, I agree with you for sure. Mhm.
When our famous a year with mercury.
Thank you.
Okay, thank you. Mhm.